Good morning, good afternoon, and good evening to our guests around the globe who join us today for the Alzheimer's Association International Conference Roche Satellite Symposium, Empowering Physicians to Advance the Future of AD Management and Care. I'm Ian Creamer, host for today's Satellite Symposium and Executive Director of the LEAD Coalition, Leaders Engaged on Alzheimer's Disease. We're a federal policy coalition based in the United States, advocating for improved quality of life for people living with dementia and their caregivers, while we also accelerate the science of detection, prevention, effective treatment, and eventually cure for all forms of dementia. Here are the disclosures for myself and the rest of the faculty for today's symposium. During today's symposium, I'll kick things off with an overview of why we need to speak more publicly about Alzheimer's disease and other forms of dementia, revealing the secret that's been too long hidden. Following my presentation, Marwan Sabal will speak about the importance of early detection and diagnosis. Carla Abdelnour will define the future, particularly moving into the use of technology to advance Alzheimer's care and treatment. And Claire Paquette will speak about the importance of improving home care for people living with dementia and their caregivers. In my talk today, I'll be discussing the secret, speaking about the hidden truths of Alzheimer's disease and the importance of getting out from under stigma and confronting this disease publicly and candidly with patients, their families, and the general public. You've already taken the most important step by joining us today. Clearly, you're ready to work with us and our partners globally to overcome stigma and, in the end, provide better quality of life for people that are facing dementia today and help provide a future in which science can advance and prevent dementia in the future. We want to empower you as physicians to build a new healthcare system and a new practice modality so that your patients, your family caregivers are partners with you in making a better future for people facing dementia. You know as physicians that the secret to progress for your patients and for their families is to focus all of your energy on moving forward, understanding what sets the foundation for your care plan, but understanding that you are trying to improve quality of life moving forward rather than just look backwards. Through today's presentations, we'll address the state of play in Alzheimer's research currently. We'll understand the disease and symptoms with respect to the whole person, not treating them just as a disease, but as an entire human being whose quality of life is measured not only by the response to that disease, but how we empower them to move forward in their life in full. And we'll discuss how we can work together to transform the future of Alzheimer's disease detection, diagnosis, care, treatment, and eventually cure. As all of you probably understand, Alzheimer's disease and other forms of dementia are truly a global pandemic. It's a hidden pandemic in many ways, not getting the attention that it deserves and requires, but something that affects literally tens of millions of people globally today. And if we do nothing to change the trajectory of the disease, a disease that will affect more than 135 million people by the middle of this century. As all of you know, you went into medicine not to treat diseases, but to care for people. If you focus on treatment of the person, and caring for them and helping them build the quality of life that is available to them and that they seek for themselves, then you will have done the truest mission in medicine, and that is to improve quality of life for individuals, understanding that a disease is just part of their life. We understand that there are remarkable tools for detection and diagnosis that are already available to clinicians, but sadly, they're all underutilized. Part of this is because many clinicians, hopefully not including those in our audience, are under the misconception that if there's no disease-modifying therapy available, that there's no point in detecting and diagnosing and conveying that diagnosis to patients and families. This is one of the most dangerous myths that we face as a dementia advocacy community. Underutilization of the available tools and those that are coming to market soon is a crisis. It's a crisis for proper medical treatment of comorbid conditions. It's a crisis for patients and families who can take advantage of available social services that are focused on people with dementia. And it's a crisis of medical ethics. There are many diseases that we cannot guarantee to cure. And there are many diseases where we cannot guarantee to slow their progression. But we still have a fundamental ethical obligation to our patients to tell them the truth. Detection and diagnosis is that truth. And if you convey in a timely, accurate, compassionate, and actionable way the truth of dementia to patients and their families, you empower them. You destigmatize what they face, and you give them the tools to improve their quality of life. You allow them to access not only social services in the community that are tailored for what they are facing and what they will face, you also give them the opportunity to manage their comorbid medical conditions, all of which can and must be managed better in the face of dementia, but only with a very clear understanding that the patient has and will develop more severe problems with memory and judgment as their dementia disorder progresses. If families and patients are empowered with that information, they can plan for that future. They can plan individually, and they can plan with you, their clinician, as a partner. And while I understand that you are at this symposium because you already understand the vital importance of detection and diagnosis, an action step you can take immediately after this symposium is to work with your colleagues. Make sure that every clinician in your practice and every clinician that you know in your community and across your country understands the vital and central importance of early detection and diagnosis that is timely, accurate, compassionate, and actionable. One of the great and most harmful myths about any form of dementia, whether it's Alzheimer's disease, frontotemporal degeneration, Lewy body disorder, vascular disease, or any of another 100 causes of the symptoms that we describe as dementia, is that people don't want to know the truth. In reality, of course, people do want to know what they're facing and what they're not facing, and be able to have a clear plan, even if the ultimate outcome is not one they would desire. People need to be empowered. People deserve the truth. It's a moral and ethical necessity for people to understand what they face. So while they're scared of an upsetting diagnosis, they do want the truth, they do need the truth, and they do deserve the truth. It's important also to rule out other conditions and for people to understand what they're facing so that they can plan for the rest of their lives. And that's not end-of-life planning alone. It's also the proverbial bucket list. People having the power to make choices, understanding what the consequences will be, and the opportunities. So if you as a physician have the right tools to detect and diagnose Alzheimer's disease and other forms of dementia, even before they cause symptoms, at a mild cognitive impairment stage or even earlier, then you are empowered to be the best ally that your patients and their family caregivers will ever have. Around the globe, we're at an inflection point. We have an opportunity to convey a diagnosis and reveal the secret that has been too long hidden by too many people about Alzheimer's disease and other forms of dementia, or we can backtrack. Today, we want you to join us in moving forward. Seize that inflection point and change the attitudes of individuals who face these diseases, their loved ones, their communities, and their governments. For too long, we have hidden behind the stigma of Alzheimer's disease, but we have an opportunity to change that. And the consequences couldn't be more enormous. With over 50 million people living with dementia around the world today, and as many as 135 million people who will have dementia by the middle of this century if we fail to take action, this is our moment. But let's understand the consequences of withholding a diagnosis for the individual, for the society. If we withhold a diagnosis, we can complicate care for medical comorbidities. We understand, for example, the enormous coincidence of Alzheimer's disease and diabetes. And if we better manage diabetes, we better manage Alzheimer's. And if we better manage Alzheimer's, we better manage diabetes. The key in each is for people to be aware of what they're facing, and for those who support them through formal medical care as well as informal family care to be aware of all the conditions and what their implications are and how treatment and care for one disease affects another. So it's much easier to care for someone with diabetes if you understand that they will not be able to manage their medication on their own throughout the course of their dementia, that they will need support for that. And if we do better caring for their diabetes, we'll make sure that they have their vision to assist them with the other challenges they face as their cognitive abilities decline. We also understand that withholding a diagnosis can deepen health disparities, which are particularly acute among people of color and women globally. There's an important aspect as well about family relationships. If families understand that their loved one is living with dementia, with an illness, a disease that causes dementia, they're likely to be more supportive and less suspicious of changes that that individual goes through in terms of their judgment, their memory, and their behavior. Stigma affects not just people with dementia, but perhaps there is no deeper stigma around the world than dementia itself. If we empower people to know their diagnosis and to speak confidently and clearly about what they have and what they don't have, to tell their story, to own their own narrative, then they can begin to be the agents of breaking down that stigma and change society's attitudes. Withholding a diagnosis is also, frankly, paternalistic. The American Medical Association declared well over 40 years ago that withholding a diagnosis of cancer was professionally unethical, and it's time for us to make that commitment in the dementia field as well. Additionally, if we convey a diagnosis, we give patients and their families an opportunity to address non-medical issues. So that could be legal and financial planning, it could be medical planning for other conditions, and it can also be making their own spiritual decisions and confronting for themselves what they want their life to look like moving forward in the context of dementia. It's also important to understand that health systems in the United States and many other countries around the world are not prepared for the coming wave of dementia cases increasing. So if we empower people to tell their story, and if you as clinicians join those individuals living with dementia in telling their stories to decision makers, we can begin to change the dynamic around the way health systems are built, operated, and eventually expanded to cope with the wave of individuals living with dementia that is coming toward every country around the globe. So you as physicians can be an agent of change, both by empowering your patients and their family members to be advocates, but also joining them in the halls of government to advocate alongside them. Help legislators and other decision makers and policy makers understand what dementia is, what it isn't, what it does to the individual, what it does to the family, what it does to the society, and most important, how policymakers can change that future. They can modernize health systems, they can change reimbursement systems, they can fund the science that will improve detection, diagnosis, treatment, and eventual cure for Alzheimer's disease and other forms of dementia. It all begins with the clinician revealing the diagnosis of dementia in a timely, accurate, compassionate, and actionable manner. We know that COVID-19 has had a particularly brutal impact on the community of individuals living with Alzheimer's disease and other forms of dementia. The slide you see now provides some statistics from the United Kingdom assembled by the Alzheimer's Society. And we understand that there are much higher rates of death among individuals with dementia, particularly those living in institutional care settings. It is particularly important that people who are living with Alzheimer's disease and dementia are aware of their diagnosis and that it's charted for medical providers who may encounter them in the context of COVID-19. Understanding that someone has memory and judgment impairment may go a long way to helping them understand how they can prevent spreading COVID-19, but also enable their caregivers and medical professionals to assist them in containing the spread of the disease. Understanding basic public health messages may be difficult for most of us. It can be especially challenging for people living with cognitive impairment. So at the beginning of this talk, I encouraged you to look toward the future rather than toward the past. If you look forward, and if you work collaboratively with your patients and their family members, you can empower them to have a higher quality of life by conveying not only the diagnosis of dementia, but giving them tools to live a full and rich life. Connect them with social service agencies in your country, connect them with online resources, and make sure that they have a full and robust care plan that is both medical and in terms of their social services. Make sure that they understand that they have a full and rich life ahead of them as long as you work collaboratively to manage the progress of the disease. Clinicians are perhaps our most important partners in the fight against this set of diseases. Clinicians have the potential to be among the most effective public policy advocates, speaking to legislators and other decision makers about the kind of societal changes that will improve care for people with dementia, improve practice for physicians who are caring for people with dementia, and create a social environment as well as a biomedical research environment that advances our fight against these diseases. Working together, we have the opportunity to ensure that what makes people themselves is what we strive to maintain. We can work proactively to preserve what makes people who they are.
Hello, I'm Dr. Marwan Sabah. I'm the director of the Cleveland Clinic Lou Rubo Center for Brain Health here in Las Vegas, Nevada. I am a neurologist by trade, board certified, fellowship trained, and geriatric neurologist, spending the majority of my career, in fact, the entirety of my career, in the diagnosis, management, research, and treatment of Alzheimer's disease dementia. The title of our talk today is Don't Define the Diagnosis, Try to Define the Verdict. Now consider this. Every 3 seconds, one person is diagnosed with Alzheimer's disease dementia or mild cognitive impairment. That shows how common, how prevalent, and how problematic this disease is in the world health. So the approach we want to talk about is, instead of trying to ignore the diagnosis, explain it away, let's see if we can take it on head on, tackle it, and try to change the outcome and the trajectory. So what are we going to cover today? We're going to cover an overview of early diagnosis of Alzheimer's disease in its current state and its future state, and review the type of tests that would and could and should be involved. We should understand how early diagnosis relates to the patient, science, and society at large, and how new developments will optimize clinical practice. I'll give this, of course, from a research perspective, but from a clinical perspective, and how we need to transform current practice to achieve what we want to achieve with the incorporation of biomarkers. We want to map early diagnosis against the key elements of the patient journey to highlight the challenges and how they can be addressed in the light of recent advances. So let's take a minute to kind of figure out where this is leading us. If you are in your clinic as a clinician like I am, patients are walking in the door, they're referred by a primary care physician. You're looking at the referral, you're trying to get a history from the patient and the caregiver perspective to ascertain clinical diagnosis, whether it be mild cognitive impairment, Alzheimer dementia, other dementias, age-related cognitive decline, or other etiological causes for memory or cognitive impairment. That is a N of 1 in that experience. Of course, we want to be able to make the population better. So instead of an N of 1 patient experience, you want to apply science and big data and epidemiological characteristics to identify risk factors and risk markers and try to see if they can be applied clinically. And then what we want to do is re-engineer, using combination of patient experience and science, to re-engineer the healthcare experience to make it more fleet-footed and efficient in the diagnosis and management of care, not just now, but in the future if we are able to achieve DMTs. If you think this is an academic exercise, consider this. The majority of patients are not diagnosed. They're either not diagnosed properly or in fact never diagnosed. And so if you look at the slide, and I'll let you read it, I want to give you an experience. I had a patient recently who had seen another doctor in a managed care organization who had been seeing the patient with a complaint of memory and cognitive impairment for over 3 years, had had a total of 9 MRI scans, all read out as mild periventricular ischemic white matter changes and mild atrophy. No stroke, no tumor, no normal pressure hydrocephalus, 9 scans later. And when I walked in the door to evaluate the patient clearly had Alzheimer's dementia, had never been diagnosed formally. The chart just said memory impairment, cognitive decline. My point is that physicians do not feel comfortable making a diagnosis of Alzheimer's disease. Caregivers are a very good source of information for incident cognitive decline, and patients tend to underreport their symptoms. So you have to take a little bit of all aspects of their care. But the bottom line is that we're delaying diagnosis, we're avoiding diagnosis, and we're not taking it head on. Now let's spend a minute to walk through this slide. If you actually look at the fact that by the time they walk into your clinic, that would be item 3 on the left-hand side for your initial symptoms. They may have had symptoms for 1 to 18 months, 12 months, 2 years, 3 years. So there's a lag between onset of symptoms and the initial assessment. There is even a bigger lag between onset of disease pathology and onset of symptoms. So if you believe the Diane study and other studies, going from box 1 to box 2 on the left-hand side could be years, 5, 10, 15 years. But we are seeing months and months of delays from onset of 2 to 3 initial assessment. Usually they go to the primary care physician. In many cases, the primary care physician might dismiss the concern, say there's nothing wrong, you're depressed, you have too much on your mind, you're having trouble sleeping. They're not taking the initial complaint seriously enough to warrant an evaluation. And so by the time they get to 4, which is me, an Alzheimer's specialist, or you as an audience as Alzheimer's specialists, could be 2, 3 years from the onset of symptoms. So that's when, of course, we want to improve 1, 2, 3, and 4 to identify them at 1, and I'll talk about that in a second, but shorten the length of time from 2 to 3 to 4, and then use the newest tools to go through 5A and B to take that clinical suspicion and make it more confident with the latest biomarkers, confirm the diagnosis, and then manage treatment with 6A and B. So that's kind of where we're at and some places where we need to go. Why did I comment about box number 1? Well, the box number 1 is the fact that a lot of data suggests that up to 1/3 of all dementia could be avoided, prevented, delayed, or postponed by modifying the risk factors, including hypertension, obesity, physical activity, etc. So we think that lifestyle interventions could be a way to change the algorithm so that we don't get from 1 to 2. So that's why I wanted to comment on it. And there, in fact, this is not fantastical thinking. There are multiple studies trying to engage in lifestyle prevention strategies. The finger study is now being done in the United States under the name of the pointer study, with essentially the same thing, that we can alter trajectory and prevent, delay, or postpone the emergence of cognitive symptoms. Now, I am sometimes asked not only why is it difficult to diagnose Alzheimer's disease, but when should we use biomarkers? Can we use them in the pre-symptomatic phase? The answer is, in the context of research, they are using biomarkers to do enrichment strategies and ascertain potential patients with disease prior to onset of clinical symptoms. But we are not using biomarker evidence in clinical practice to detect patients who are bound to become clinically symptomatic for MCI or dementia. In other words, we only use them once they have presented with a clinical symptom and clinical cognitive impairment. The reason we want to do that is, of course, enrich for clinical trials, but prepare patients so that we could avoid a future that involves an incident dementia. So let me take a moment to kind of walk you through this slide. This is an important slide because it's the state of our current existence. A patient will have cognitive symptoms. He or she will have a cognitive complaint, hopefully corroborated by an informant. Physician, if they take the concern or complaint to heart, might do a bedside screening, and in so doing a bedside screening, mini-cog, MoCA, SLUMS, mini-mental, they might then proceed to do a diagnostic evaluation, which would include physical neurological exam and a diagnosis of exclusion, meaning B12, TSH, MRI, etc. Why am I talking about it from this perspective? Because we learned in 1984 from the NINDS ADRDA criteria that you could only diagnose Alzheimer's disease with an autopsy or biopsy confirmation. So definite Alzheimer's disease was felt to be related to autopsy or biopsy confirmed. What it did is, of course, even in medical school, I learned you could only diagnose Alzheimer's with an autopsy. Consequently, we approached it with the idea that we were going to exclude other conditions like thyroid disorders, mass, stroke, hydrocephalus, etc. In 2011, they recasted in the NIA working group criteria, which basically said that biomarker evidence was considered advisory but not essential. And so still to this day, in 2020, we see biomarker evidence of inclusivity not routinely incorporated in clinical practice, at least in the United States. And of course, we're using only clinical criteria to diagnose Lewy body dementia. You do not see much use of dopamine transporter scan, FDG PET, or cardiac MIBG scanning. And of course, for frontotemporal dementia, the best approach without directly observing proteinopathy is use of FDG PET. So I'm saying too that biomarker evidence is still considered advisory, but not essential, which is unfortunate. I mean, if you look at this is what is known as the famous Cliff-Jack curve. There's not a meeting in the Alzheimer meeting that you go to that you cannot see the famous Cliff-Jack curve. I want to move you from right to left on this, on the left-hand panel figure. From right to left, of course, by the time they come into your clinic with the clinical symptoms of mild cognitive impairment or dementia, their brain is full of a pathology. In fact, the earliest incident change is in changes in CSF amyloid followed by PET amyloid. So amyloid is changing long before the onset of symptoms, maybe 10, 15 years or more. And so the first seminal event is the accumulation of amyloid. We do know that not all amyloid species are kind of considered to be toxic, and the monomeric might be considered to be nascent, and it is the oligomeric species that might be considered to be toxic. But the bottom line is there's an early seminal event, and only after that does the brain start to have detectable amounts of CSF tau, and then you get the neurodegeneration, that is the hippocampal atrophy and FDG PET changes, and then you get the cognitive decline. So you know, the use of biomarkers could be informative both as a diagnostic, meaning the right-hand side, but also in a predictive value. Could you use biomarkers to predict who's going to progress to dementia? And the evidence from Lascia and Abney suggests the answer is yes. But biomarker evidence is kind of in a split manner. If you really look at it, the data and the research is outstanding and very, very robust, but has not been translated into clinical practice. We are now looking, if you look at the ATN, amyloid tau neurodegeneration criteria, which is mostly a pathological construct. You do realize, of course, that we have reasonably good ways to measure amyloid and tau with PET and CSF. But the question now is becoming apparent is, can we measure neurodegeneration? And the answer is yes. Hippocampal atrophy using the neuroquant scoring, below 5th percentile, is a marker of neurodegeneration. FDG showing parietotemporal hypometabolism is a marker of neurodegeneration. And most recently, the emergence of plasma neurofilament light, or plasma NFL, is a marker of neurodegeneration. Ideally, though, you want to look at neurodegeneration in conjunction with direct markers of amyloidopathy or tauopathy. So the biomarker evidence we would use now is using the CSF or PET. Ideally, we would love to use blood-based biomarkers and to detect amyloidopathy or tauopathy. We do have research markers of cholinergic changes and neuroinflammatory changes, but they are not being developed, at least as of right now, as commercial assays for detection of biomarker evidence of Alzheimer's dementia or Alzheimer's disease. So here's a summary of where we're at in the field. If you actually go from bottom to the top, amyloid imaging is considered to be approved, and as of just a few weeks ago, tau PET was approved as well. We know that amyloid PET is what considered to be binary, so positive, negative. Tau PET the use of Tau PET is still being decided. Structural imaging is still mostly used as a diagnosis of exclusion for mass, stroke, hydrocephalus. Of course, we're using more quantification scales, but the problem is if you have no evidence of neurodegeneration, it does not mean you don't have a amyloidopathy or tauopathy. It just means you haven't had sufficient amount of atrophy to qualify as neurodegeneration. The CSF markers are very, very specific for the disease, amyloid, total tau, phosphorylated tau ratios, and they're all being looked at. Until now, the most common assays have been using measurements of amyloid, total tau, and phosphorylated tau to create an ATI index, amyloid tau index. But we hope very soon we'll be able to use plasma amyloid A beta 42 as a candidate to screen for Alzheimer's pathology. Let me spend a minute to talk to you about the fact that right now we have, going from right to left, the Alexis platform has been approved and is used in Europe to detect levels of amyloid, phosphorylated tau, and total tau. We know that the Alexis platform reference ranges are different from other assay ranges, like you have, for example, the Quest Athena has different ranges. So you have to look at their reference ranges for each individual assay. It's important also is that we see next gen, generation 2 coming online. These assays have great specificity and sensitivity and could have tremendous diagnostic accuracy. We are very close, very, very close to the idea of seeing blood-based biomarkers emerging as screening tools. And understand that blood-based biomarker will not be inherently diagnostic, but might be a screening tool for negative predictive value. So a normal value would exclude the possibility of target pathology, but a positive value would warrant a second-tier level of evaluation like a CSF testing. And so many assays are being developed, and I'll comment on that in a minute. The specificity and sensitivity are very good. So in Alzheimer's disease, dementia, and in mild cognitive impairment, you see amyloid levels go down, A beta 42 in particular, because there's a belief that the amyloid A beta is sequestered in the plaques, lowering the amount in CSF, but it is very highly predictive for MCI. And we know that below a certain threshold, the prediction of progression is very high. We also know that phosphorylated tau is a more specific marker of tauopathy in the setting of Alzheimer's disease, and total tau can go up from a concussion, brain injury, stroke, and so therefore is not specific. So, but we expect total tau to go up, but more importantly, we expect phosphorylated tau to go up, and so therefore has a good specificity, but not tremendous specificity for other dementias as well. So, and it is predictive of progression. So the bottom line is that reduction in tau, elevation of phosphorylated tau, and total tau are markers of Alzheimer's disease. There are a lot of companies that are in this space, and we could have approved use or commonly used platforms for plasma assays within the year, and CSF assays, 2 have been approved, 2 are nearing approval, and we expect to use them more and more. The debate in the US often centers around, are we going to center on PET tracer utilization in clinical practice or a CSF utilization in clinical practice? And that debate will continue. But I do want to make a point about CSF testing. One is that CSF testing can be used and is used for other disease states, such as meningitis, such as multiple sclerosis. So use of CSF testing in clinical practice is common and routine, and there's no reason it can't be used in Alzheimerology. Second is that the clinical diagnosis of Alzheimer's disease is terrible. Some estimates are as low as 60%, but best case scenario is 77%. So we are wrong as a field, even amongst experts, we're wrong between 1 in 3 and 1 in 4 times. So therefore, CSF testing could tremendously improve the clinical accuracy of a diagnosis. The idea that nobody's using biomarkers is also a misinterpretation of what is happening. In Europe, it is clinical practice, standard practice, particularly in Scandinavia, Germany, and other parts of Europe, to do CSF testing as your diagnostic approach, so it's done routinely. Not so in the US and not so in the UK, but it is something that's being done in other parts of the world. The next thing, of course, is that people say it takes a long time. Certain platforms do take a couple of weeks to get results, but the Alexis platform can have a turnaround time in a matter of days instead of weeks. The idea that it is expensive is, I think, a misinterpretation. The CSF testing right now costs about $175 to do the lumbar puncture, and it costs about $1,300 to do the CSF analysis currently. That still puts a total cost of about a quarter of what an amyloid PET costs and gives you more information. The assays are getting good enough that you could see that the total cost could be, 1/10 the cost of amyloid PET, and therefore it is informative and might still be a first tier choice above amyloid or tau PET. I want to summarize a lot of things. I've already spent a lot of time talking about the left-hand side of the slide, but we want to transition to the right-hand side of the slide. And that is to say, going from a diagnosis of exclusion to a diagnosis of inclusion. And so if you use a tiered approach, maybe use plasma amyloid first, and then if it's abnormal, go to CSF testing or maybe PET testing. That could really improve your diagnostic accuracy from 66 to 75% up to 90+%. Why do we want to do that? Why is there an imperative to do that? Well, the answer is that an early diagnosis could delay, postpone, prevent cognitive decline. It could allow access to new treatments as they become available. It could reduce total costs, and we could improve quality of life. In fact, the ultimate thing we want to achieve is for people who don't have dementia, we got to take the long view, is that we want to delay, prevent, postpone the emergence of symptoms so that you have fewer years with dementia. And for the people with dementia, we want to maintain what they have so they don't get worse and they can maintain whatever they have and maintain their quality of life. If you look at it from a kind of a macro view, a 20,000-foot view, look at it from this perspective. If we know a person with dementia, Alzheimer's disease, symptomatic Alzheimer's disease, has a roughly 10-year life expectancy, we want to shrink the back end where we know that 33% of their life at this time is spent in institutional-based care. We want to shrink that from 33% down to 5%, so that then they don't spend their life in institutional-based care. And so you want to front load their life and diagnosis and management so that they can stay at home and stay having more quality of life for longer periods of time. So that's what biomarker evidence will allow us to do. And so the guidelines will come along. I think the guidelines are not quite there with the approach of biomarker evidence as a diagnosis of inclusion, but they're coming along. We want to use that as a way of screening patients potentially for clinical trials, get them ready for DMTs, get them ready to get treatment as quickly as possible. And then we want to use this as an opportunity to set treatment expectations. And so we want to use it to improve symptoms and reduce decline over time. People talk about the elephant in the room. Well, there are a lot of elephants in the Alzheimer's space, and one elephant you need to consider is this. We don't feel comfortable making a diagnosis of Alzheimer's disease dementia. And therefore, we are delaying the diagnosis, we're delaying the access to treatments, and we're delaying how we transform care in Alzheimer's disease. And so if we can re-engineer the strategy, include biomarker evidence, we can address the elephant in the room in a way that improves quality of life and improves outcomes. So the conclusion here is that an early diagnosis leads to preserving more of what makes people who they are, gives them more time in their home, more time without progressing through mild cognitive impairment into dementia and maintaining a good quality of life. and setting expectations so that families can plan accordingly and deal with the future with confidence. Thank you.
Thank you for listening to this presentation entitled Defining Future, a Period of Time Following the Moment. So I will start this presentation by explaining you the main objective of the talk. Here we will share with you some new concepts about digital medicine and remote monitoring. And we have here the outline for the presentation. We will have an introduction. We also talk about the limitations of the current instruments for assessment. We will share the concepts of digital medicine and remote monitoring, and we will talk about the benefits and limitations of the digital assessment. We will also explain remote monitoring, and we will share with you some final remarks. I would like to start this talk by sharing with you this quote from Edwin Powell Hubble. It says, "Past time is finite, future time is infinite." Hubble was an astronomer famous for providing evidence for the universe expansion, and the Hubble telescope is named after him. And thanks to this marvelous instrument, we have been able to determine the age of the universe. We have been able to look the seasons on other planets, and we have also seen the first image of a planet in visible light. The Hubble telescope is proof of how technology can help us to advance our knowledge and understand the universe. We as neuroscientists also have other questions to answer, sure as complex as understanding the universe around us. One of these questions is, how can we cure neurodegenerative diseases such as Alzheimer's disease? But to find a cure for Alzheimer's disease, we need to address several issues like why some proteins start to accumulating in the brain in the first place, or why some brain structures are more susceptible than others. Another question is, how can we measure in a more personalized way the cognitive and functional decline of Alzheimer's disease patients? Fortunately, for this last issue, now we have available the technology to develop more precise and reliable tools for cognitive and functional monitoring. Here we have the patient's journey from the presymptomatic phase, the onset of the symptoms, to the confirmation of the diagnosis. Here we can see in this dotted red line that we could use data collection from the patients to perform an early detection of symptoms, even maybe in the presymptomatic phase. That will help us to reach a wider population and probably start treatment at early phases. Also, this digital assessment could be used in the treatment and management phase because carers can use digital assessment to track the symptoms of their relatives, and the medical team can also look at the adherence of the treatment of the patient. Also, it would be very nice to have data on the several modifiable risk and protective factors that exist at different points across the lifespan. That way, we could have a fingerprint of each individual modifiable factors and use them as a treatment and probably as a prevention for developing Alzheimer's disease. But why do we need these tools? Don't we have already good instruments to diagnose and assess Alzheimer's disease? Well, we have a wide range of instruments, but they are often misunderstood and misused, and they waste valuable diagnosis time. We need to appreciate important consideration for the tests currently used, because sometimes we don't know if they are clinically meaningful, if they reflect what people find most important, or if they are accessible to all of the society. So making advances depends on overcoming these current limitations. Additionally, there are other limitations for the instruments we use today because they are performed at specific time points. As we said before, they are time consuming, they require self-reporting, and they are subject of rater variability. Therefore, here we have some room for improvement, and one possible solution comes from digital medicine. Digital medicine is a field concerned with the use of technologies as tools for measurement and intervention in the service of human health. Its goal is to provide evidence to support the use of these technologies. These technologies are called digital medicine products, and the products are driven by hardware and software components that support treatment, recovery, disease prevention, and health promotion. Digital medical products can be divided in medical products that include digital biomarkers, electronic clinical outcome assessments, and tools to measure adherence and safety. We also have intervention products that are digital therapeutic and connected implantables, and we have combination of both. For example, continuous glucose monitors for diabetes share patient data automatically with their doctor's office using a companion app. Digital medical products use remote monitoring, and the concept of remote monitoring implicates the use of digital devices for monitoring activity that in the case of Alzheimer's disease will range from cognitive to functional, behavioral, and physical data. These devices can be sensors, wearables, and implantables. And this type of technology can report activity patterns over time and gather more accurate information. Currently, digital assessment is not widely used in the evaluation of Alzheimer's disease patients, but we are facing an Alzheimer's disease patients epidemic, and we think these tools are easy to implement and could be widely developed and distributed among the communities to evaluate patients with Alzheimer's disease and even to improve the screening process. How self-monitoring can support people? Well, self-monitoring is crucial to raise awareness of own behaviors and emotions, because that way I will be able to know my own symptoms and track them a long time. In clinical settings, the monitoring of patients generally occurs periodically, as we said before, in different specific time points, and the approaches are varied widely. Some of them are by computer, by telephone. The feedback either comes from face-to-face or via technology. But in the future, digital self-monitoring intervention offer a promising e-health solution. But one can wonder, what will be the benefits of use this remote monitoring? Well, first, we will have personalized precision medicine because the data collected could be a cognitive and functional fingerprint of the subject. We also will have real-time monitoring. It could be that we will have continuous and long-term monitoring on follow-up that could be minimally invasive. This offers us an efficient way to early detection of cognitive and functional changes, and also they could be used as digital biomarkers that might help to accelerate and optimize clinical trials because we can use them as novel endpoints and we can measure adherence or identify adverse events. Now I would like to share with you some examples of the possible use of digital medicine. First, we have here face memory. Face memory is the first verbal memory test self-administered with voice recognition developed in my institution by Dr. Montserrat Alegret and her team. It is administered on a tablet with voice recognition and a touch screen, which can be automatically corrected, registered, and saved in a database. Face memory is a computerized version of the F912 with images representative of the Spanish population. In Fundación ACE, we have used face memory in 300 participants, cognitively healthy and MCI subjects. Our results shows that face memory seems to be a sensitive tool for the detection of the cognitive impairment and is also highly correlated with the pencil test format. Also, it has shown excellent acceptance by the users who have confirmed that they would like to repeat the test in the future. The acceptance of the user for a test is very important because that way we can ensure that they are engaged in the task and the results that we're going to obtain are objective and reflect the reality. Also, it's important for the test not to be burdensome for the patient because otherwise the results could be misleading. Another good example of how can we use digital assessment is the MOPEAD project. MOPEAD stands for Models of Patient Engagement for Alzheimer's Disease. And the aim of this project is to deliver a step change in Alzheimer's disease patient engagement strategies and a paradigm shift from late stage diagnosis to early detection. One of the runs of MOPEAD is the Citizen Science Run, the Run 1, that can use a neuropsychological online tests. We believe that this is a nice way to approach individuals for screening that otherwise wouldn't be evaluated in a clinical setting. Also, this strategy is easy to implement and we can reach a wider range of possible candidates for clinical trials. Third, I would like to share with you an example from the multiple sclerosis field. This is Floodlight and is an app developed by Roche for multiple sclerosis patients. It's not for Alzheimer's disease patients, but I think it's a good example of how can we combine different ideas to monitor our patients. This app contains a range of active and passive monitoring tests that measure a person's ability to perform simple tasks on their smartphone. And in that way, the patients can gain more knowledge about their symptoms. This really helps to empower patients, and we hope that one day we in Alzheimer's disease are also able to empower our patients in their symptoms and in the importance of understanding the disease progression. That way, we enable them to accurately identify changes and engage in informed patient-led discussions. This will never replace a healthcare professional. Rather, it has the potential to bring together the patient and professionals in a more personalized relationship. So I want to finalize by talking to you about some previous experience I have with technology, because I know sometimes technology can cause some reluctance because it's associated with drastic changes in the labor market. But we have experienced similar transformations in the past and we have been able to adapt. So I think at the end, the benefits are worth it. A good example of how technology has helped us is the COVID-19 crisis. The other day I was reading an article about a non-profit organization called Code from Venezuela, and this was important for me because Venezuela is my hometown. And I found out that they are implementing two projects. One chatbot for screen users for COVID-19 symptoms and provide a risk score, and an analytics project providing a virus risk for surveillance systems. So I think this is a very nice idea to help a country like mine that are struggling with the virus. And this is just one example, but there are several others, from drones transporting both medical equipment and patient sample to the use of robots in COVID facilities. But here my point is that if we have been creative enough to use the technology to tackle the COVID pandemic, we can also do it to improve our knowledge and to find the cure for Alzheimer's disease. It's also important to know what is the opinion of the regulatory agencies. Here we have a comment of the FDA that says that digital medicine are tools that can provide patients with a wealth of easily accessible information that can help them make better and more efficient decisions, take steps to improve their lifestyle and health choices, and experience better outcomes. In conclusion, I would like to finish with a positive note by thinking of all the future possibilities that we have ahead of us with the tools provided by technology. As this quote says, imagination will often carry us to worlds that never were, but without it, we go nowhere. It's time for us to expand our limits by using our creativity and imagination, because the future is now. Last but not least, I would like to thank our amazing team of professionals of Fundación ACE. We truly are making Alzheimer's history. And of course, I would like to thank Roche for this kind of invitation.
So thank you very much for inviting me to talk about this important topic about the home of AD patients. I am Claire Paquet. I am the head of the Cognitive Neurology Center at Université de Paris Lariboisière Hospital. As home of everybody, and including AD patients, it's really important. And as Roger Walters said, everyone's got somewhere they call home. So today we will try to cover at home or home-based management of patients since the earlier stages, the future at home in the context of disease-modifying therapies, and reducing the need for scans by enhancing supplementary approaches. As my colleagues have already presented, this slide is presenting the patient journey from the pre-symptomatic stages to the later stages. I think the home-based management and evaluation should occur at the very, very early stage of the patient at onset of the symptoms. And maybe if we are able to evaluate at the onset of the symptoms, we would be able to diagnose AD earlier than now. This home-based management should continue to the latest stages of the patient, including treatment, including neuropsychological evaluation, and including autonomy evaluation. Our home or our house is really important in life. It is the mirror of our personality. It is also a refuge at the same time. So this home is a base of our life. It allows us to grow up, it allows us to build our family, and it is a protective refuge. But cruelly, Alzheimer's disease seeps into this refuge and progressively dissolve the links between the patient's, his or her home, and with the family. So that's the reason why I think home evaluation and home management is really important. And I have been advocating this idea of home evaluation for several years because I think it's the only way to get a real evaluation of the severity of the disease. At all stages of the disease, symptoms of AD occur in daily life and are not linked to the medical interventions. The main challenge of AD is to keep the independence of the patient. I mean, to prevent the loss of autonomy. Everybody knows that, and the real objective in light of this challenge, the real objective of future therapy would be the autonomy of the patients and to preserve the autonomy of the patient. In line with the real objective, we have 3 points that we have to consider. First, the home-based clinical evaluation, to get the real idea of the autonomy, to get the real idea of the severity of the disease. The second one is a home-based treatment and readaptation to be as close as possible of the patient. And the first one is the home-based clinical and therapeutic follow-up in order to measure the efficiency and the safety of therapeutic and of the future therapeutic. Why currently we don't evaluate the patient at home, or so not really evaluate patient at home, not at the beginning of the disease. So why should we evaluate at the beginning? You know, many people don't want to be evaluated at home, but we know that 60% of the patients live at home in France and in the world. The evaluation of the patient gives us a real reflect of the autonomy, including drive the car, use the money, and if professionals go to home, they would be able to perform an unbiased quantification of the difficulties and the abilities of the patient, and this way of evaluation is much better than the questionnaire used with the carrier, with the caregiver of the patients. And autonomy needs a professional evaluation. You know, the caregiver is not a professional, and very often the caregiver is a spouse of the patient, and it's difficult for him or for her to give an objective evaluation and to quantify the abilities of the patient. This home-based evaluation would be the opportunity to educate the caregivers and the relative of the patient to give the best idea of the severity of the patient. And the most important thing, that the home evaluation and management would be the best evaluation of the efficiency of the future therapy. And I mean that we would use it in clinical trial. So how could we evaluate the autonomy at home? How could we manage the patient at home? There are two main ways: mobile professional teams at home that we already use in France and in other countries in Europe, and the using of new technologies. Concerning the home-based clinical evaluation, in France we have mobile professional teams which are called Équipe Spécialisée Alzheimer. The objective of these teams is to evaluate the autonomy in the daily life and to put in place the necessary help adapted to the difficulty of the patient and to the environment of the patients. So they have 15 sessions with the patient. It's free for the patient because it's included in the social insurance. And during this session, they evaluate neuropsychological tests, very short neuropsychological tests, just to give an idea of the severity of the disease. They really quantify autonomy daily life, ADL score, because they check it with the patient and the caregiver, and they don't only ask the question, they really check it. And they go further by evaluating other function, for example, check spatial orientation, that it could be a problem, use the money, use the credit card, use the TV, radio, everything in the daily life. And they give up a real reflect of the abilities of the patients. In the second point, they help caregiver to realize the severity or not of the patient and to explain the abilities and the limits of the patients. As you can understand, this is really different from our consultation-based evaluation or hospital-based evaluation. In an hospital environment, we only have indirect evaluation of the autonomy and abilities of the patient. Except for neuropsychological tests, we don't have the real capacity in daily life of the patient. This picture gives an idea of the environment, and it's obviously the home evaluation is much better to evaluate the autonomy, but to evaluate the treatment. So based on our experience with the Équipe spécialisée Alzheimer in France, we observe sometimes some discordance between our clinical evaluation, medical evaluation, and of autonomy and the home-based evaluation. For example, when I diagnose my cognitive impairment due to AD, based on my neuropsychological test and the questionnaires with caregiver and patients, I am not concordant with the home-based evaluation because the team observed a lack of loss of autonomy. So I have to change my diagnosis because this patient is not independent anymore. There is a loss of autonomy and he presents major cognitive impairment and not my cognitive impairment. So I have to change the diagnosis and I have to change the management. At the opposite, sometimes these mobile teams show that patients with a moderate stage still have an acceptable autonomy based on routines. In this case, we don't change our diagnosis, of course, but we change our management and we change the help that we bring to the patients. Thanks to this team, we also have access to more precise autonomy data. As already said, the spatial orientation, the spatial orientation is a very early symptoms, and that could be dangerous if the patient is lost. So it's an important element to record, symptom to record, and we are not able to record it in a consultation. We also access to the ability to use the credit card in real life or to use cash money, and the ability to open their home with key or codes. These teams help us to improve the awareness of the caregiver when patients are evaluated in front of the caregiver. Sometimes the caregiver realizes the patient's ability or the patient's limits. Finally, at home, we are able to perform the infusion and the perfusion thanks to nurse at home, and this is very helpful currently for clinical trial and will be very helpful in the future with disease-modifying therapy, and it will be also very helpful to follow up the safety and the side effect of the patients. So, using home-based infusion and home-based treatment, it would be, of course, easier for the patients, and we would be able to treat every patient everywhere in every country, at the opposite of infusion performed in the hospital. Based on the nurse at home, we would be also able to follow up the safety of this treatment, and in the future it will be very important using the disease-modifying therapy to put in place this home-based management of the patients. It would be too complicated to hospitalize all patients because there would be several million of patients. So the the professional people at home are really important, but we could also use to evaluate and manage patients at home new technologies. And new technologies are the field of new technologies are very wide, and it wasn't possible to cover this field today. So I will talk about 3 points: neuropsychological evaluation online, that it could be good during the COVID pandemic, of course, but it could be good to follow up the efficiency of treatment or to follow up the evolution of the disease. Evaluation of the autonomy is just a beginning, but with connected tools, we could evaluate the autonomy, or using robot, for example, and improvement of the autonomy using the training, for example, e-coaching. For the first part, about the neuropsychological evaluation, I have given you two examples of neuropsychological evaluation online. During the COVID pandemic in France, in Paris, we have several thousands of patients of COVID patients during the pandemic, and Alzheimer disease patients didn't want to come to hospital anymore, and they didn't want to see the doctor anymore. So we used the online neuropsychological evaluation to measure the evolution of the disease during the pandemic, to diagnose new patients, and to also measure the psychological impact of the COVID on patients. So I have given you two examples just to show you that it's possible to evaluate patients online. I think many teams are developing online neuropsychological evaluation because of after pandemic COVID, we are changing our procedures everywhere in the world. So concerning our own tools, I wanted to talk about a short test, and this test could be used at home, but also could be used during consultation, and could be a link between both locations of evaluation of the patient. This app is called MemScreen. It's a free app on smartphone. We have validated in French, and we are validating in English using the Whitehall cohort, the huge English cohort with 12,000 people. This app could be used to the first evaluation of cognitive function, just a screening, and this screening could be done at home, or it could be done in consultation, or it could be done with a nurse, it could be done everywhere. This is an auto test or a test with MD. So to give an example, the first screen we record the demographic data just to calculate the norm and the results in comparison with normal population. And after, we present 12 rods to the patients, and we ensure that the words are encoded by identifying the words using a clue. For example, here there is "what is the fish?" and the patient has to answer cabillaud, the French word. In the second part, to give a distractive task, we ask spatial orientation, calculation, intrusive similarity task, and time reading. And at the last step on the right, this last step is devoted to the recall of the 12 words. After, the result is very easy because we have the memory score with normative results. We have the second part of the score, executive score, and the total score. And we also have the cognitive speed of the patients. So we measure several neuropsychological fields with the cognitive speed. It's very quick. You see, it's 2 minutes or 3 minutes, and we could perform it at home, online, with the patient. So with the medical doctor and the patient. So we are able to follow up the patient. For example, when the patient is not good, we can ask the caregiver to perform this test with the patient and to send us the result. So it's a very good way to use a neuropsychological test, either online, either on auto test, either on consultation. Other tools are the connected tools. So everybody knows the connected tools now because everything is connected. And the connected tools are really interesting, mainly for early Alzheimer's disease, and we use it a lot because we measure the independence of the patient in using the connective tools, and mainly mobile phone. So we are able to check if the patient is able to use the mobile phone, the connected mobile phone, using connected app with him. This connected tool is very helpful for spatial orientations concerning 2 points. First, the evaluation of spatial orientation, and this is the only way to really evaluate the spatial orientation when the patient is alone without anybody. And the second point is that it could be helpful for the patient to help him to find his way when he is in his neighborhood or in the town. The first point is the therapeutic observance. This point is already used in other diseases like diabetes. So far, we have few treatments in Alzheimer's disease, but it could be really important to be sure of the therapeutic observance of these few treatments, and it could be really useful and important in developing treatment. For example, in clinical trial, we have to count the pills during the consultation. With the therapeutic observance, we would be able to follow the therapeutic observance and to prevent toxicity or safety of the patient. So connected tools are really useful to help patients, of course, to plan and memorize activities, and there are many apps to help AD patient with memorize meals, appointments, taking medication and everything. And during the COVID pandemic, we realized and we set up communication with family using a connected tool, and we have used robots, and the robot is able to find the patient in the home to establish a visual contact with the family. This is the beginning of this connected tool. In the future, there will have many other connected tools that will be more helpful for the patients and for the relatives. Finally, this connected tool will be very important to follow up the patient and to follow up the clinical evaluation of the disease and the safety of the treatments, mainly with future treatments. As I said before, the home-based infusions will allow us to treat every patient everywhere in every country. This will be the same with online evaluation, with online neuropsychological evaluation, but online safety evaluation. We will be able to follow a clinic evolution and treatments of every patient everywhere in every country. Concerning the follow-up of the patient, there is another element, another point that we have to consider. This is a training. A part of the treatment of AD is based on the training of the patient, cognitive training, and sometimes sportive training. And we also have everywhere in the world platforms who are proposing cognitive training. For example, I have given you two examples: Happy Neuron, which is French, and which has been validated for the cognitive training, the online cognitive training, and Lumosity, which is an American platform, and which is very good, and it's already used in France during the re-education with either caregiver or professional. Similarly, there are many applications for motor training. They don't propose specific motor training for AD, but many platforms and many apps have been developed, for example, for Parkinson's disease, for the motor training of Parkinson's disease. So I think the take-home message is thanks and based to the COVID pandemic, we have to realize that it's necessary to be as close as possible to the patient, to develop home-based evaluation, management, and follow-up of the patient using mobile teams, mobile professionals, but also connected tools. And this topic raised several questions, and maybe in the future, literature and scientific research will answer these questions. The question is, do we really understand the impact of a safe home environment in terms of AD patients, of the disease progression, in comparison with is measured with the clinic? I have shown you that we in France we have difference between the home-based evaluation and the consultation-based evaluation. How could we prepare society, medical doctor, professionals, patients to keep patient at home at longer as possible, using new technology and other possibilities like a mobile team? And if we would like, I think we are able to diagnose very early patients, but if we would like to measure the impact of Alzheimer's disease very early enough for the patients, we would be able to manage earlier the patients and help to prevent the evolution to the AD major cognitive decline. And I would like to finish on another kind of home. I know that there is this kind of home in Netherlands, and it's very new in France. We have the first AD village. So they have built, society have built a home for specifically dedicated to AD patients, with shop, with bar, with everything. And even if patients have lost their autonomy, they are independent in this village. So I think it's a new way to think the home, the future home of patients with major cognitive decline due to AD, when we are not able to prevent the evolution of the AD. Thank you for your attention.
Thank you for joining us for today's symposium. We appreciate that you are here for the right reasons. You have chosen to attend this symposium because you want to be an active member of a collaborative that is changing the face of Alzheimer's disease and other forms of dementia today and into the future. We hope that you will join us in being committed to using all the available tools for detection and diagnosis and advancing care and quality of life for people living with dementia. You are the conduit through early detection and diagnosis and through assistance in reaching care planning services and social services. You can also advance the science. In collaboration with people living with dementia and their caregivers, you can make clinical trial opportunities available. You can support those patients and their families as they engage in those clinical trials, and you can help deliver to them the results of those clinical trials through the advancement of science. Thank you again for joining us today and being part of our movement to improve quality of life for people living with dementia. You are essential collaborative partners. As we seek to improve detection and diagnosis, care, and treatment for people living with dementia, you, the physician, are the catalyst. Take every opportunity that you have to be an advocate with and for those in your care. Be an advocate to make sure that they can overcome the stigma of dementia, that they understand what they face and what you will support them in facing. Be with them as they advocate for change in the halls of government as well as in the broader society.
My name is Sean Kennelly. I'm Director of the Memory Assessment and Support Service here in Tallaght University Hospital in Dublin. While COVID was a challenging time, some of the positives that we identified was how we were able to channel that multidisciplinary team of speech and language therapists, occupational therapists, neuropsychologists, all led by our nurses here in the memory service, to be able to informally link in and support the care of our patients with dementia and their families during the COVID period. And Kathy McHale, our advanced nurse practitioner, will explain some more how we did that.
Yeah, so once there was a time that our families, our patients couldn't come into us, we actually needed to evolve and to make links with our community partners in order to deliver the care that we wanted to provide. And it actually became a time where we were able to deliver some very important messages around brain health, around the importance of diet and exercise, social connectedness, and the importance of being aware of their mental health, especially in a time of COVID, and promotion of sleep. So we turned it to our advantage, really, in a time when we couldn't get them in to see us.
Thank you.
So thank you very much.